Great. So I'm Catherine Thompson and I head up the Cardiovascular Disease Prevention Programme at Public Health England, and I'm chairing today's webinar. And I'm really pleased that we're joined by the team that undertook the work on the update to the Rapid Evidence Review for the NHS Health Check Programme for us. So we've got Louise Tanner, Ryan Kenny and Fiona Pearson, all from Newcastle University. And we're going to hear directly from Louise and Ryan on the call. And then we've also got Rashmi Bardwaj-Gosling, who's joining us from Sunderland University. And Rashmi will be joining us as well for the question. Rashmi and Fiona will be joining us for the questions at the end of today's session. So we've got an hour for this webinar, and it will take the style or the format of a presentation from Louise and Ryan, and then an opportunity for questions. And as I say, you can post those questions once we've enabled the instant message box, or please do so using the audio and speaking directly to our presenters. Great. So I'd like to hand over now to Ryan. Thank you, Ryan.
Yeah, hi, welcome everybody. It's great to see so many people here. So obviously myself and Louise are going to go through this rapid review update that we undertook, looking at the NHS health checks. So we're both from the Evidence Synthesis Group at Newcastle University, and we've worked with our colleagues Rashmi and Fiona to complete this. So we can move on to the next slide, please. So slide number 4. So just to reiterate what the objectives were, so these were the 6 objectives that were identified in the original rapid review that was undertaken. So objective 1, who is and who is not having an NHS health check. Objective 2, what factors increase take-up among the population and subgroups. Objective 3, why do people not take up an offer of an NHS health check. Objective 4, how is primary care managing people identified as at risk of CVD or with abnormal risk factors? Objective 5, what are patients' experiences of having an NHS health check? Objective 6, what is NHS health checks' effect on disease detection, changing behaviours, local risk management service referrals, individual risk factor prevalence, CVD risk, and statin or antihypertensive prescribing. And if we just move on to slide 5. So starting with objective 1, who is and who is not having an NHS health check. It's important to be upfront that most of the data is pre-2014 still, with only one singular community-based study conducted post-2014. And obviously there's the Public Health England NHS Digital which offers national data up to 2018, and they show that an overall attendance rate has remained at about 40 to 50% nationally. Throughout the literature, males have consistently been reported as less likely to attend than females at a regional level. There is, however, a singular study suggesting in a community setting that males may be more likely to attend, suggesting that it can vary depending on community. In most cases, increase in age led to an increased likelihood of attendance. So if you're over 60 years of age, they were most commonly reported to attend. When services were available out of hours, however, younger people were more likely to attend. So maybe this is due to differences in scheduling. For example, older people over 60 years old are more likely to be retired, whereas those under age 60 are more likely to be in employment and therefore may not be able to make it during normal operating hours. There's quite little data looking at which ethnic groups are more likely to attend. Some national data suggests that white people are more likely to attend, but then when you look at community level data, it suggests that non-white people are more likely to attend. So further research is needed to really pin down what ethnicity groups are more or not likely to attend. The original review identified that those individuals from a lower deprived background were less likely to attend. However, we've started to see a little bit of literature suggesting that those from a high level of deprivation are less likely to attend. So again, this is still kind of up for debate. So when we look at the checks being completed opportunistically rather than by invite, we get a greater attendance deprivation levels. There's also some evidence to suggest that smoking status can affect attendance, so people who are smoking are less likely to attend than non-smokers. Those from a higher level of deprivation, and smokers are obviously considered high-risk groups, and we should really find ways to increase attendance in these subgroups. We use something called GRADE, which assesses the overall certainty of the evidence for each objective. The evidence for this objective was originally graded as being low because most of the studies are of an observational nature. If we just move on to slide number 6, looking at objective 2. So what factors increase take-up among the population and subgroups? So the NHS Health Check has maintained an uptake of about 45 to 50%. Uptake is defined as those who attend an NHS Health Check as a proportion of those who have been invited. Recent national data published by the Public Health England reports an uptake of 45.9% for 2018-2019, but this does vary across region and constituency. So if we're looking at the North East, for example, it varies between 25 and 61% uptake. And then this variation is even greater again at a local authority level. Only one study presented socio-demographic factors of uptake. This study overall supports the previous trends from the first review. So females and those over 60-year-old are most likely to take up a check. Little evidence again in way of ethnicity and background, while those from a higher deprivation level were less likely to take up an invite. Previous evidence was attained from observational studies, whereas this new study was an RCT, but it was only conducted in 2 London boroughs, meaning its results cannot be extrapolated to the wider population. So then there are obviously different things that we need to look at on how we can improve this uptake. So if we move on to the next slide, please. So slide number 7. One of the ways that we may improve uptake is by looking at the different settings. So GPs had a greater uptake when it was done opportunistically. However, more people from the highest deprivation level attend outreach services. And additionally, more people of a South Asian ethnicity showed a higher uptake when we were looking at people in a community setting. Outreach services may increase uptake in harder to reach groups, such as South Asians and those from the highest deprivation level. So like we're looking at kind of pharmacies, etc. Possibly patients feel more engaged by the opportunistic type of face-to-face invites rather than letters, emails, as this was determined from 2 studies. More evidence is obviously required. Which brings us nicely on to different types of invite methods. If we can go to the next slide, please. So in this one we had 5 RCTs and 1 cohort study, which added to the previous 7 studies. One of the most improved ways of inviting people was including reminders through text message, which increased the uptake. Additionally, telephone invites improved uptake, as did performing the invite opportunistically, as I've previously mentioned, compared to the standard letter. Altering the letter format did not appear to have any effect on uptake due to the low number of RCTs. The evidence here was rated as very low. Qualitative studies support the notion that people prefer to be contacted by telephone or in person, suggesting that they prefer that more personal touch compared to a letter. Okay, next slide please, number 9. So objective 4, how is primary care managing people identified as at risk of CVD or with abnormal risk factors? So the NHS Health Check aims to help attendees understand their level of CVD risk and provide support for those who are at risk. One quantitative study identified in the current review completed a 6-year follow-up with a match control analysis. This study is at a national level using the CRPD data. Over the 6 years, they observed attendees compared to non-attendees had a decreased risk of CVD and decreased BMI, smoking prevalence and blood pressure. Additionally, there were increases in lifestyle advice, so smoking cessation, prescriptions for statins and antihypertensives. So we're kind of suggesting that this one study is the checks are doing what we would hope. And the qualitative evidence in this update also supports the previous review, with healthcare professionals expressing doubts about long-term cost effectiveness and adequate training. Again, most of this evidence comes from pre-2016, so there is still quite a big gap of what's happened in the kind of last 4 years as well. So I would like to pass over to Louise from here, and she's going to continue. Thank you very much.
Thank you very much, Ryan. So could I ask Alicia, please, to move to the next slide? Thank you very much. Sorry, I'm just trying to move my my image up from it's kind of currently blocking my view of the PowerPoint slide. I'm not sure how to do that, but anyway, I'll just continue. Okay, so I'm going to present the results in relation to objectives 5 and 6. So objective 5 was what are patients' experiences of having an NHS health check. So there were no new quantitative studies and 2 new qualitative studies that were identified in the review update, which provided data that were relevant to this objective. And from the 2 new qualitative studies, no new analytical themes were identified. However, the data from these studies fed into 3 of the themes that were identified in the earlier review by Juliet Usher-Smith et al. So the first theme, which the data from the 2 newly identified studies fed into, was understanding the risk score. So it was found that patients had limited understanding or memory of their cardiovascular risk score. However, individuals are more likely to remember their risk score if they'd had concerns about their cardiovascular health prior to attending the NHS health check. And the second theme was quality of information, and it was found that patients were more likely to recall a conversation with their GP about the cardiovascular health rather than a risk score, and patients were particularly satisfied when they were presented with a graphical risk report. And it was felt by the researchers who undertook this primary study that maybe that was because the for patients with either kind of poor scientific or health literacy, or individuals where English language wasn't their first language, the graphical risk report was kind of more accessible and easier for them to understand. So the third theme was being a potential trigger for behaviour change, and it was found that individuals were most likely to report that they had changed their lifestyle following having an NHS health check if they were supported by their sort of social networks, particularly where sort of changes were implemented at the household level. So, for example, where dietary changes were made for all individuals in the NHS health check attendees' household rather than for the attendee specifically. So there were several barriers were identified to behaviour change, and one of those was genetic determinism, which relates to the assumption that patients had that if they had relatives who'd developed cardiovascular disease, that regardless of any change in lifestyle, the individuals themselves would also develop the condition, or conversely, if the individuals didn't have a family history of cardiovascular disease, then those individuals are more likely to kind of believe that they themselves were at kind of low risk and wouldn't need to make any lifestyle changes. So it should be noted that there could be an element of socially desirable responding with individuals reporting that they had changed their lifestyle following the NHS health check, just because it's kind of a socially acceptable thing to say, when in fact it might be the case that they didn't in fact change their lifestyle. So evidence contributing to this theme, the overall quality of evidence assessed using the GRADE tool, which Ryan mentioned, the evidence was rated as kind of low to moderate quality, and the issues with the quality, with the evidence feeding into this into objective 5 were kind of social desirability bias and also responder biases. It's likely to be the case that people with particularly strong views who are more likely to kind of express those to the researchers, and therefore that could kind of bias the results in a way that kind of makes the reader think that that kind of represents all of the patients who kind of undertake the NHS health check and sort of participated in that research when that's not necessarily the case. Limited objectivity of the methods used to collect data which fed into this objective. So in the earlier review, quantitative studies were identified which asked patients' opinions of the NHS health check. Survey data are not necessarily not objective, and also kind of qualitative evidence it isn't objective. And also there were inconsistencies in results between the quantitative survey data which indicated overall satisfaction with the programme and the qualitative evidence which identified particular issues with the programme, some which I've already mentioned. So now I'll move on to, could we move on to the next slide please, Alicia? Thank you. So objective 6 was what is the effect of the NHS health checks programme on, and there were various sub-objectives. Now 13 new studies were identified, quantitative studies, which fed into this objective. So the first outcome of interest was disease detection, and it was found that the NHS health checks programme led to an overall increase in the detection of cardiovascular disease and its risk factors. However, the effect did vary, particularly in relation to different kind of demographic factors, such as deprivation level. So, for example, it was found that individuals who were from most deprived backgrounds are most likely to have a CVD risk of greater than 20%. So in relation to the next sub-objective, where we assess the effect of the NHS health checks programme on changing behaviours, in similarity to the earlier review, the only behaviour change assessed was smoking, and an overall reduction in smoking prevalence was found in relation following the NHS health check, either compared to baseline or a control group. However, the effect did vary between studies, and one of the new studies that we identified for the review update indicated that the reduction in smoking prevalence was actually greater in the control group compared to the intervention group. So the next sub-objective, we looked at the effect of the NHS health check programme on referrals to local risk management services, and the referral rates varied according to the kind of type of risk factor being addressed, and also between studies. It was found that the overall that individuals were most likely to be referred to smoking cessation programmes and to kind of weight management programmes, and were least likely to be referred to support programmes in reducing alcohol consumption. Next slide please, Alicia. Thank you. So it was found that overall reductions in cardiovascular risk factors were found across studies. However, the effect kind of varied between in relation to the risk factor being assessed. So consistent reductions were found across studies in relation to diastolic blood pressure and cholesterol, but some null effects were found in relation to systolic blood pressure and cardiovascular disease risk score. However, none of the studies reported increases in any of the risk factors assessed following the NHS health check. Next slide please, Alicia. So the next sub-objective that we looked at was the effect of the NHS health checks programme on reducing prescribing of statins and hypertensive medications, and consistently it was found across studies that there was an increase in statin prescribing amongst those who attended an NHS health check. However, 1 in 5 studies reported a decrease in antihypertensive prescribing following the intervention. And in relation to the economic evidence, it was found that cost effectiveness of the NHS health checks programme could be increased through combining the current provision with targeting towards deprived areas, and also incorporating policies to target kind of dietary consumption. It was also found that although the NHS health checks programme is associated with only modest reductions in BMI, these modest reductions can lead to significant cost savings for the National Health Service. So in terms of the evidence from the grade process in relation to Objective 6, the evidence were rated as very low to, the evidence were rated as being very low to low. I apologise, my camera is blocking part of the PowerPoint slide. Yeah, the evidence were rated as being kind of very low to low, and the factors which influenced which resulted in that rating included the observational nature of studies. So observational study designs as opposed to randomised controlled trials, which are more robust and internally valid. Also sort of high risk of bias scores, again reflecting the observational nature of study designs, but also things like the assessment of smoking status based on kind of self-reported data, and also inconsistencies in results between studies, both in relation to effect size and actually in some cases direction of effect, and the level of significance of the findings. Next slide, please, Alicia. Okay, thank you. To conclude, the number of published studies has increased by 43% since the last evidence review. However, most of these studies were published using pre-2014 data, and therefore do not necessarily reflect the situation over the last 6 years. The certainty and confidence in the evidence has been judged to range from, is actually from very low to moderate, so quite variable. And so I would say the kind of the overall strengths in the evidence included that for some objectives, certain findings were supported by a variety of different study designs. So you've got kind of triangulation of kind of from quantitative and qualitative evidence, and also some of the quantitative studies use national data sets which are kind of more representative of the population of England and are likely to provide kind of more precise results with small confidence intervals. Overall weaknesses would include the observational nature of most of the study designs, and variation between studies and the definitions of outcomes and exposures, and also kind of follow-up times as well. There were a lot of kind of variations between studies which prevented meta-analysis from being undertaken, and inconsistent results in relation to effect size, in some cases direction of effect, and also significance level. So there is a need for more kind of large methodologically robust studies, i.e. RCTs or matched observational studies that use kind of standardised data and standardised kind of definitions of exposures and outcomes in order to comprehensively evaluate the NHS Health Checks programme, its effectiveness and cost effectiveness. And that is the end of the presentation. Thank you all very much for listening, and we look forward to your questions.
That's super. Thanks, Louise and Ryan, for doing such a fantastic job of compressing all of those findings into a really concise summary. That's really helpful. And I think it's great to see that the evidence has increased, but also a little bit worrying that a large chunk of the new studies was, as you've highlighted, pre kind of 2014, because obviously we want to ensure the evidence continues to develop and build on the programme. Nationally, within Public Health England, we have been working on an analysis of a sizable data set, over 12 million patient records, and we are due to be kind of publishing some initial findings of that very soon, and we'll be running a webinar actually on the 18th of November to talk about that a bit more, and that picks up on some of the findings really highlighted as well through this study in terms of who's more likely to attend a check, and some of the patterns we're seeing about smokers being less likely to come along, for example. So there's certainly more to come, but thank you for that excellent summary.